We appreciate it. Dr. Castro is a neurologist and specialist, and she just actually opened her own clinic that serves the broader community regardless of insurance needs. So I just wanted to say thank you. This will be on our website later for everybody to see. If someone you know was not able to make it, if you want to rewatch it, it is there for you and your needs at any time. So with that, I will go ahead and hand it over to Dr. Castro to start, and I will go off video and mute myself, but Dr. Castro does want this to be more interactive. So if you do have any questions, please go ahead and raise your hand, and I will go ahead and unmute you and allow you to ask that question. So just so you guys know that. All right, I'll hand it off to you. Thanks, Dr. Castro.
Thank you so much. And again, I apologize. I hate to be late, but I'm sure you guys have experience in the clinics. Usually they take longer than you want. So like you were saying, I am neurologist and neuromuscular specialist, and I was with the University of Texas Southwestern for 14 years. But I decided to leave academia because there were many things that I felt that we could do better in a private setting. And one of those was offering coverage for more people, regardless their insurance. So we see pediatric and we see adult patients, and we see people with or without insurance. So we are trying really to be able to offer the best care we can as the patients get older. And it's interesting because I'm going to talk about transition of care, and I see it as I am not transitioning my patients to another neurologist, but I am transitioning my patients to other specialists, like the adult specialists, adult cardiologists or adult pulmonologists. But I am going to be permanent, at least for the next probably 20 years, for my patients with Duchenne, my patients with other neuromuscular conditions. So I wanted to start like with the definition, right? Like we have this transition of care applies for every chronic illness, for anybody that has, for example, cystic fibrosis, anybody that has those chronic conditions, diabetes, that are going to require to move those clinics from the pediatric side to the adult system. And it's almost like the ideal situation will be like kind of handing off from the pediatric to the adult provider. When does that happen? It depends your hospital, it depends your clinic. There are some institutions that by 18 years of age, you have to be on the adult system. There are some of them that can hold it up to 21, 22 years of age. Why? There are some situations where the transition may be influenced by a specific trial. I'll give you an example. I have one of my patients who was on one of the FibroGen trials. He turned 22 and he still was at Children's when I was working there. And he was still there at 24, 25 because he needed to continue the trial. But that doesn't mean that he was not going to an adult clinic. That doesn't mean that he was not getting the care somewhere else. So the trial could hold him, but the care itself needed to be somewhere else. And also access to treatment. Some of my patients, if I have an authorization for a medication and I know it's going to be hard to get it on the adult side, many times I just had to try to hold them as much as I could. Like in my place, like it says, in some places, neurologists may continue caring for the patient across their life. That's my idea. And why? Because I think that Duchenne is Duchenne in early age, is Duchenne later on as adults. It is the same condition with a lot of changes, but the core is the same. So I think that we as neurologists have the capacity of continue seeing them. But the problem is that you do have to get other people that are specialized more in the adult issues, like the pulmonologists, cardiologists, gastroenterologists, and so on. What are the barriers that we have for transition? There are some things that are pre-existing factors, right? There are some things that are there. They're there for all of us, for every single patient. So finding a qualified practitioner in the adult care setting, I can tell you that has been my headache. It is my headache of my life right now, because what I found is that the adult practitioners, they really have different goals in life, right? Like it's more about the number of patients they see a day. I talked to a cardiologist who says, who said to me, I see 20 patients in the morning and 20 patients in the afternoon. And to me, it was like, I do not understand that. I see 3 in the morning and 3 in the afternoon, right? So their way to practice medicine is different. And the other thing is how interested they are in the conditions that we're dealing with, because these are rare conditions or ultra rare conditions that now patients are surviving and going through life and going through adulthood where before they did not. So there is not, the knowledge is many times is not there, or the interest. Then other things that limit it are your insurance coverage, your finances, right? When I opened this place, I thought that I was going to get more people without insurance, with zero insurance at all. That what I'm really getting is people underinsured, meaning you do have a Medicaid, but your Medicaid is really crappy and it's not getting you get this study or the other one, or seeing this specialist or seeing this, these doctors at different sites. So I'm receiving a lot of patients that have not been able to be seen at UT Southwestern or Parkland or any of the county hospitals because of their insurance. So we take them here and we work with a sliding scale. The other thing that says aging out of publicly funded or parent-sponsored insurance plans. As you know, many of you as parents, you know that if you have a private insurance, you can have your son up to 26 years of age. But at that point, that person is going to have a plan by themselves. So that's what it means in these cases, is when the patient is under the parent insurance, but that run out. There are other things, there are other barriers, for example, poverty and low parent education. I have seen that a lot. And unfortunately, a lot of my Hispanic population, that has to be with culture as well. It's almost like, oh, we got here, everything has been working well until up to 18, 21 years of age. But now what is coming is too hard for me to do, too hard for me to deal. I don't speak English. I don't understand. It's all of those things that unfortunately are there and that are very hard to deal with. And then the complexity and instability of the condition. So to me, what is extremely worrisome is when the patient is 21. I give you an example. I had one of my patients who was only 20. He had a testicular torsion. He needed to be seen urgently in the hospital, but he was my patient because he was still 20 at Children's. I sent him to the emergency room at Children's. They didn't want to take him. They say he was an adult and he needed to go to the adult hospital, even though I was his physician at Children's. So that is the problem, that instability in those years of life are the ones that make me really worry about not having transitions or plan for transition really well developed before. There are other barriers, right? Like developmental immaturity. Many of the patients, adolescents or young adults, they are not ready to assume responsibility. And I'm not going to say how to do it because I don't know. I'm the type of mom that did a lot for my son who is 11 years of age. And sometimes he still asks me to tie his shoes. And I know that's wrong. So I don't know, because I don't know what I will do if I had a son with Duchenne. I'll probably be overprotective. I'll probably be doing a lot of things for them. But that is an issue that we're seeing now, is that because they are surviving, because they have a longer life, we're not letting them assume the responsibility for their condition. So something that I do is when the patients come, I try to talk to the patient, looking at the patient mainly pretty much the whole visit, most of the visit, to try to engage them more. Most of the time, the patient will turn and look at the mom. And that's okay, but it's a little process that we can start working through. And it's nobody's fault. That's what I'm saying. It's just something that we have to deal with. Lack of knowledge, medication and illness, transition process, lack of provider knowledge. That is the biggest issue to me, is that, again, I have been trying to find a good cardiologist for the adult side. We had Dr. Mammon here before, who used to see patients with private insurance only. And he left. And then after he left, we pretty much don't have a provider. There are 2 other providers, but I don't know really how knowledgeable they are about Duchenne. But the case is that we need to have more providers that understand these conditions and that are interested in these conditions. How do we get them interested? That's the question, you know. I can get the pediatric cardiologist interested in 1 second, and I have an amazing group. How do I get the adult cardiologist interested in this kind of thing? So if you guys have ideas, please help me. Skills and efficacy. Provider institutions are unable to support the transition. And when it says burnout, I'll say that was my case. I burn out in medicine. I almost leave medicine because the problem is now they're pushing you to see so many patients so fast because medicine has changed. And now the one that is making decisions for you is somebody in administration who doesn't know anything about medicine. So unfortunately, we're pushed to see so many people that you end up burning out, and you obviously don't have the time, don't have the money, don't have the structure to be able to do a good transition of care. So a lot of things that are there that are barriers and barriers. And when I do the solutions, I think I'm going to have less solutions that really the barriers I'm presenting. So belief and expectation. Many people, there are some papers cited there because this has been looked at it, not for Duchenne, but for in general for chronic illness. Many people think that the quality of care is not as good on the adult side because they spend less time that we pediatricians, we spend with patients. It may be real, in many situations. I'm getting some adult patients here that I had a guy who said to me, and I thought that was very sad. He said, Dr. Castro, you have spent more time with me than any other doctor in my life, and you have treated me like a person. And that is really sad to hear because this is where medicine is going, is in and out, get in and get out. Are the providers caring, knowledgeable? Are they experienced like the pediatric providers? Again, we don't know. The relationship that we create with the families, it provokes a lot of anxiety, a lot of worry about how is that going to look now that you go to the adult system. The pediatrician, us pediatric neurologists, we have a hard time to let it go. That's why I'm not letting it go. I'm keeping my patients because I'm not good at letting it go. Protective parenting are limiting the self-management and foster dependence, meaning what I just was mentioning, that as moms or dads, we are trying to do a lot of things for them and not letting them take responsibility and ownership. There are some situations where the patient cannot take that responsibility because cognitively they cannot, right? And then there are other things like depression, anxiety, the stress of life, the family, how it's functioning, denial of illness. So what are the negative outcomes of all of those barriers? Non-adherence, yes, that's what I'm saying. Like many of the Hispanic families will not transition because they're not, this is too hard, it's just not gonna work. And then they may go once and they will never come back. I did a study last year before I left UT where I looked at around 400 patients between the ages of 22 and 45 years of age, and that have graduated or have left the system. And I tried to collect as much information as I could. And I found that very interesting that most of the American families who had private insurance, they were able to continue following up with all the specialists. So I had patients that had neurologists, gastroenterologists, endocrinologists, orthopedic, they had a whole beautiful list. And those patients were still alive, many of them 34, 35, 36 years of age, right? And then I had the other ones that had many times are Medicaid, many times Hispanics that went to one appointment and they never went back, and they unfortunately passed away. So adherence is extremely important, and that's why this is so important to talk about. Missed medical appointments, poor health outcomes. That's what I'm mentioning with the same comments. So what are the solutions? What do we do? You know, I think ideally allow patient interaction with adult providers before transfer. Yeah, that's nice to say, but how do you get it done? I think the only way to get that done is if you have a joint clinic. And that was something that I suggested at UT for years. I said, we should have a clinic where the pediatric team and the adult team are seeing the patient, at least for a couple of visits before the transition is 100%. I think that's the only way, really. or have like what I have, right? I have two different teams, one for pediatric care, one for adult care, and I'm in the middle. Beliefs and expectations. For those barriers, allow patient interactions with adult providers before transfer. Again, ideal, not easy to do because the doctors are not going to have time to meet with patients even before they see them. Create a structured transition plan or utilize individualized transition plan templates. They have all of the foundations, and I know Jett Foundation, you guys have resources that where you can pretty much is a checklist of all the things you're going to need to be able to transition to the adult care. So for some families that are well educated, that have the time, that have the energy to do it, some of them do it amazingly well. Most of them don't. Connect patients with peers who have already transferred. I think that's another good key of these, is that there are adult groups that are happening already for patients with Duchenne and Becker that I think are extremely important, because in those groups, I attended one meeting, for example, and I heard things that I'm like, geez, I will never even think about it. They knew about which type of wheelchair was better for them. They knew about in that area which doctor could see them, right? So I think that that's a really good place to start if your son is interested in joining one of those, or if you as a patient are interested in joining one of those. Other thing that we can do, provide tours on the adult clinic. Yes, can be done in some places, cannot be done in some places. Begin transition preparation in early adolescent. I think that that's important. And I think we can do, as pediatrician, we can do a much better job, start talking about these things early in life. So for example, something that I start doing is that after 14 years of age, I'm going to start asking you your medications, and I'm going to drive you crazy. You're going to have to learn at least one of them for the next visit and for the next visit, if there is the cognitive capacity of that, right? Because I want that patient to be independent. I want that patient to own their own condition. Then access insurance. What can we do? You know, regularly assess and discuss transition readiness. The problem with insurance is that it really varies so much. And now that I'm in private practice, I'm understanding even better how many issues we have. Like, for example, with Medicaid. If you get just a little more money than the one you needed to get, you're going to lose Medicaid coverage, right? So there are so many things that unfortunately, I wish my hope, my dream right now is to have a social worker that is pretty much specialize in these type of things, because we need somebody who can try to help us navigate in the system. Something else that, and to that, sorry, and I'm going to mention something about that. Social Security is something that I was very surprised. One day I had two families with adult patients, and one of the very similar families, you know, in terms of demographics, education, everything. One family has gone through the process to get Social Security and they were denied. And the other family, very similar, had gone through the process to get Social Security, they were approved. And I asked the family, what did they do? They actually use a consultant. Am I asking you, all of you, go and pay $150 for a consultant? No, but I think we need to find a way to understand what is it that person can do better to try to help other people, because it varies even within very, you know, proximity in terms of families. Any question until now? Anything that I can answer, or anybody wants to make a comment? And please be, you know, this is easygoing. I'm very easygoing. So if you have anything that you want to mention, or in the chat.
So one person in the chat did say that they were able to stay with their neurologist and their clinic, but have had to move their cardio.
Yeah. And again, that's one of the things that I think I really love the model to be able to do it like that, because I'm one of the ones that get more attached than anybody else. So it's really hard for me to let it go. And I just feel that we can still do a really good job in general, taking care of these patients.
Yeah. And we also do have a question. They have 2 sons with DMD. One is 12 and one is 8. The younger son has Medicaid, but the older son's application was rejected and will be 4 to 5 years until he gets Medicaid. Any suggestions?
That is, no, but they can reapply. Why? They can reapply because if one of them, it is by income in the household, right? So it is a combined income. So unless something has changed in the income, then that's why it was obviously denied. But that doesn't mean they cannot apply again for the next cycle.
Yeah, and Mark actually, who is a social worker, put this in the chat as well. Denials can be appealed and should be won. DMD is on the compassionate allowance list, meaning it's an automatic qualifier based on condition. And he said the application process is done, but yes, absolutely.
Yeah, but that's the thing. It's like, well, Mark, I'm glad you're here. It's like they will know sometimes the tricks that we all don't know and are so helpful because yes, it's right. It is Duchenne. You have the right to be, but it's also Duchenne. You have the right to have Social Security. It's on the list of Social Security, and one of my family gets denied and the other one gets it. Right. So this is all the injustice to me that people shouldn't have to go through when you're already dealing with enough at home,
Yeah, he did also say income limits still remain, of course, but I will to the person who asked the question, and I will connect you with Mark because I think that might be a good connection. So I'll definitely reach out to you after and connect you with Mark and see if he might be able to help you a little bit more.
I think there are more comments if we want to go through those or anything else.
One said, my neurologist is more or less my care coordinator with my pulmonologist and cardio, etc. And then I actually would like to be able to bring my son to your clinic. I like his care team so far, but some of them aren't that knowledgeable about DMD. I would recommend, I will go ahead and send that person the information to your clinic as well and have them reach out directly. And then I really love your approach on wanting your patients to be independent and treating them like a person. And I absolutely agree.
Yeah. Yeah. But it's one of the hardest, I'm telling you. My husband keeps telling me, stop doing this, stop doing that, because I keep doing it. We're mamas. And that's the way we are. I think it's part of our brain. But really, if we want to help them more, we have to try to make them more independent. That is key. Alex, I think, is there something else coming?
No, it's a follow-up against with the other question. That's all.
And there is one in the Q&A. Do you look at that one?
Yeah. Yep.
Okay.
He had reapplied and his son's like 5,000 number in the interest list. So I'm just going to connect him later.
Yeah, that will be great. Yeah, because I think, Mark, can you go online and may I ask you a question? Is he there?
Yeah, he's here.
Hello, Mark, is there besides Social Security, there was something that they sometimes here they do in Texas, and I don't know if it's a level like federal level, but there is this program for children with disabilities. Is this something that people can also apply earlier in life?
It depends on what exactly that means, and then it might also depend on what Texas looks like.
So it depends on each state. Sometimes there are programs for children with disabilities, depending on the state, I'm guessing.
Yeah, there are different programs, and things like Medicaid waivers should exist in every state, and they do, but every state plays it different. So sometimes waivers like great for DMD, and then Texas, I think it's particularly not great for DMD. So
yeah, unfortunately, it's like we're one of the worst actually for healthcare in terms of access to healthcare. And the problem is for you to get Medicaid here, I think the salary also it's different. Could you explain, Mark, can I ask you about like the level? When do you access Medicaid? It's different according to the salary you're getting, but each state has a different threshold. Is that correct?
I would need to double check to see if kind of the usual threshold is the same across states or not, because I normally look into like Medicaid waiver, and part of what it waives typically
Mhm.
is parental income from consideration. So waivers are usually a good thing to look into, because even if somebody would typically be ineligible for Medicaid based on parental income, Medicaid waiver is a way to get it despite that. It just kind of overlooks the income limit or income requirement and really focuses on the actual need. So I'm not sure what
Okay.
exactly that looks like in every state.
Yeah, but you see the complexity. It's like, it's,
Oh yeah,
Oh,
Jesus.
for
it's
sure.
nuts. I would always say like I was paid a full-time job to understand it, and even I was sometimes just like, I don't know, stuff happens. They
It,
don't even understand it, so
it
it can be
is.
maddening.
I mean, the other day I heard from somebody else that said he had $2,000 in the account. That was the reason the Social Security was denied, because I
Well, and
think
that's Cheryl just actually said her son applied for SSI after 18 and they didn't ask for the household income, just her son's, but he can only have $2,000 in his bank account and they're in Massachusetts.
it's 1,500 here.
Yeah, so it depends. And then Susan also said some of the programs in Texas go by the parents' income. There's a rider, she forgets what it's called, but there's one called Money Follows the Kid. It's based on the child's income. So again, it is so, and I'm in Florida and we're not great in terms of, benefits either. But yeah, it really is so specific per state too.
But Alexa, can we, like you guys as foundation, is there any way anybody can start, something to be able to get all of this knowledge in one place? Because I feel that that's something that is missing in general from.
We are working on it.
Perfect. Yeah, I think it's very important. So the other thing I wanted to talk really quick was about the documents require 18 years of age, because this is something that we also forget about it. And whenever the patient is already 18, then the poor parents are struggling on what to do about all of these documents. So the first one is a healthcare proxy. It's the same thing as healthcare agent or medical power of attorney or healthcare power of attorney or durable power of attorney for healthcare. All of that is the same thing to say healthcare proxy. And it's only saying that there's an authorization to make medical decisions for that patient, and also to be able to access medical records and the ability to actually have a conversation with the healthcare provider. And it's interesting because now that I see adults, we're asking them to sign that, in the entrance, you have to, if you don't have a healthcare proxy, as a mom or dad, we cannot talk to you. We have only to talk to your son. And then, all of these things are things that we have to be on top and work on way earlier and not wait until the last minute. But also to this healthcare proxy, I was filling up a form, I think yesterday, for one patient who the mom is asking to get the healthcare proxy and financial and pretty much all the proxies. And unfortunately, there are questions they ask about that are hard to answer, cognitive level. Is the patient going to be able to choose a person to marry? I'm like, I don't know. I probably, there are so many things in all of these that don't make sense. But the point is, try to get it done as soon as you can. Do not wait until last minute for this one. The HIPAA, we ask you to do it here. And if the patient is 18, you have to sign HIPAA release. And it's only saying that the healthcare providers, in this case, myself, can disclose the information about you to anyone they specify. So you have to be specific to say, you can release my medical information to my mom and my dad, for example. Durable power of attorney, that it comes to be, that's different, the one from health, this comes to be more about the financial part. So one, it designates an agent or a parent to make financial decisions on the patient's behalf. The other one, that can provide the power immediately after signing, or if the patient becomes incapacitated. So that can be specified. So if that man wants to continue having power of his financial situation, but want to have kind of like a backup plan if something happens, then you can still have a durable power of attorney in place. And it also allows people like the parents, if they decide to designate agent to sign taxes, return, access bank account, pay bills, make changes on the financial aid package, or figure out tuition problems. So all of these things to say, also important, but it's also something that can go back and forth. It's not a straight line that once you give power of attorney, then you cannot do anything as an individual, as a patient. A living will. I said right here, this is the parents, no parent wants to think about it. Nobody wants to think about this. And I don't think, not only Duchenne, nobody wants to think about this in general. And unfortunately, it's something that we have to. In these conditions, we have to think about. So a living will or advance directive, same thing. Specify the personal choices about life extending medical treatments in the event that somebody cannot communicate their wishes, right? There are different types of living or living will that can be specified. One of them is do not resuscitate. So that's what we call DNR. The other one is do not intubate, DNI. But there is another one that's a modified DNR, for example, where it says you can do compressions, but you cannot give me medications like atropine or epinephrine or anything to get you back. You can do air, but you cannot do compressions. So all of those things can be specified. And again, nobody wants to talk about this, but we have to talk about this. We have to. It's not an option. And then the last one is the FERPA waiver. FERPA, it's really for educational rights. It's called Family Educational Rights and Privacy Act. So it really protects the patient's privacy in terms of educational records. So if the patient goes to school, to college, for example, and the person doesn't want anybody, to be accessing the records, they don't have to do anything. But if they want their parents to access records and to get all of that information, then there will have to be a document. That I learned. I did not know about this one. So I think that's my last one. I am, I'm very, very happy to where I am right now, but I struggle also, like all of you, is trying to find good people, because to me, knowledge is there. The knowledge, you can find it, you can learn it, you can learn the protocols. Cardiac protocols are cardiac protocols, you can follow the protocol. But finding physicians that can see it and that can listen and that can talk to the patients and really treat people like they should be treated, it's what is hard. And believe me, we're all struggle on this. So I take any advice from anybody. I take every single, if you have recommendations about where to go with insurance, things like that, please let me know. We have an email right there. It's called newpatient@neuromdcenter.com. And then we have the website. I do have the Neurology and Neuromuscular Care Center. Is a nonprofit private practice. That's where I see the patients. And under the same roof, we have Neurology Rare Disease Center that is for research. I am doing research right now. We're gonna open very soon a protocol for Becker patients, and also opening others for Duchenne muscular dystrophy. So let us know if you have questions, if you need to come to us, just please let us know. And anything, Alexa, anything that you want to go through the chat?
There's nothing right now, but we are putting a state-by-state resource guide together on all things in terms of like Social Security and stuff like that. However, Little Hercules I don't see any specifics to like Medicaid waivers or anything like that, but they do have a resource list just so everybody knows that exists. But yeah, we are working on that, and we do have a list, so getting that up I think would be beneficial. But does anybody have any questions? Please feel free to raise your hand if you'd like to ask them out loud. Put them in the chat or the Q&A. I'll give it a little bit, but Dr. Castro, I just wanted to say thank you, and Mark, thank you for your expertise as well. And thank you for making this such an interactive webinar and giving us your knowledge and your expertise, and being real and honest about, the situation. And the realistic solutions, because you're right, you know, you can say what you can say, but how does that actually work? But I do think, you know, there are clinics, I was saying before you hopped on, you know, we were just in Minneapolis, you know, a few weeks ago, and they have that bridge clinic where they have that setup where they have the neurologist who can work with adults and pediatrics, but have different specialists around them. And also, you know, Colorado Children's has a very similar program. And I think moving toward those in, you know, in general for all clinics and all clinicians would be, you know, a really good way to go. And starting, like you said, even if it's a few visits, or really, I think Colorado Children's does it for like a year before they actually transition, where they have them come in and have some of the same nurses and have some of the same staff. So it's an easier transition is definitely beneficial, but as you said, not always, you know, done. We do have a question. Who are the decision makers when it comes to setting up a bridge clinic or generally setting up DMD adult care?
Who are the decision making?
So like if you were like at UT Southwestern, for example, who would you have to go to try to create, or just in general, right? It doesn't have to be UT Southwestern.
Too many people you have to go through, because let me explain to you something, and I'm very real. I say it like it should be, but the problem is that when you work in a system, you work with something called RVUs. So RVUs is a measurement of how many patients you're seeing. A new patient will give you a score, an RVU. A follow-up patient will give you another number. And there are some numbers that you have to reach to be able to be considered a good doctor, pretty much, to be able to consider productive. And those numbers are ridiculously high. So for neuromuscular, I always insist that we shouldn't have those numbers, because neuromuscular is extremely complex. Nobody can see a patient in 15 minutes. If you're being seen in 15 minutes by a neurologist, something is wrong. So that's the problem, that when it comes, so you have those limits with the RVUs, and that represents money for the hospitals. So the problem is that when I start, for example, insisting to have these clinics, a transition of care clinic, then the question is, so where is the money coming from? Because the problem is now I'm going to pull a pulmonologist and I'm going to pull a cardiologist not to be productive anymore, because they're not going to be able to see 40 patients a day in my clinic. They're going to be seeing maybe 10 max in a day, right? So your RVU number went all the way down. So who is going to cover that piece in between? That's what the question is, right? And that's where the administration are the ones that take decisions about that. One way to go is having funding. For example, my clinic is supported, not 100%, but my Duchenne clinic is supported by Cure Duchenne, for example. So I have the ability to provide nutrition service for free. I have the ability to provide physical therapy eval for free. So that's another way, you know. So sometimes working with universities is extremely, extremely hard, because they're beasts. These places are beasts. They are too big. And I think the model that I'm doing, it may be something that will be able to help in rare diseases. It's having a private model, doing as a nonprofit, and try to get sponsoring, you know. I have to say, I love all the advancements we're having in Duchenne and all the trials and all the beautiful things that are coming, but I'm very afraid that now we're going to end up with a huge population of patients that are going to grow older, that are going to have their needs, that are going to have so many things that are going to be, and there is no support for that. And Alexa, the ones you mentioned are the rare ones. That's not the common one. I mean, here in Dallas, this is a huge city, and we really don't have right now a decent clinic that goes from the pediatric to the adult side, right? So I think it's something that I think that industry has to think about. I think foundations have to think about, and I think families and patients are the strongest people I have ever met in my life. And many times are the ones that get things done. So I think that that's my way. That's a very long answer to say, I think we have to take control of this, because large institutions are not going to do it. they're not interested in that.
Honest answer. I love it.
Yeah.
Well, we don't have any other questions. Everybody is thanking you for your knowledge. I again appreciate and everything that you've done, and thank you for hopping on and sharing your knowledge and your expertise with us. A lot of people did ask for the presentation. Are you willing to share that with me so I can send it to them?
Of course, yeah. It's I'm embarrassed sometimes to talk about this because it's a lot of the problems and very little solutions, but we're getting there.
But you know what, it's important that we talk about it, because it is, like you said, it is so important. And we do, especially with treatments and everything that's out there now, we do have, the ability to transition our care. So it's a huge gap, and it's something that's really important. So thank you. And if you have any questions that you think of after the fact, she has an email here. You can also email me, alexa@jettfoundation.org, and we will make sure that your questions get answered. Looks like one just popped in. More of a statement, but the science is moving fast, and unfortunately the disease progression is much faster. So yeah, we definitely need transition as quickly as possible. So definitely understand that. So thank you all for being here. We have our next webinar coming up on July 13th about special needs trusts. So make sure you hop on for that. But again, Dr. Castro, thank you so much. And thank you all for being here. We couldn't do it without you. So thank you for being patient. Thanks, Char, for your story and your sharing that with us. So we hope to see you again very soon. And again, we appreciate all of you. Thank you for being here. Have a good day.
Thank you so much. Thank you so much for the opportunity. Bye.